Welcome back to another episode of Grand Rounds in Atopic Dermatitis. My name is Shanna Miranti. I'm a dermatology physician assistant from Naples, Florida. And I am joined by the lovely and brilliant Dr. Shahriari, who is joining me today to discuss some cases in atopic dermatitis. Dr. Shahriari, welcome.
Thank you for having me.
Absolutely. Let's dive into your first case.
Of course. So I'm going to talk about 16-year-old Xavier, and he came to me with an intensely itchy rash on his face, arms, neck. And it was interesting because he was most bothered by the darkness of his skin. He has a history of atopic dermatitis since he was a young one. And when talking to him about how this impacts his day to day, he has difficulty engaging in sports. When he works out, his skin burns, it gets more itchy. Past medical history was positive for allergies, asthma. And on exam, his body surface area wasn't too bad. It was 7%, but it was moderate. And his itch score was a whopping 8. So this was someone who was significantly being bothered by what was going on. So when I saw him, the patient conversation really centered around topicals versus systemics. And when I see my patients in clinic, I like to give them a bird's eye view of all the options to ensure they know that they have alternative options just in case the first treatment doesn't work. Because I kind of feel with our AD patients, in the past, we promised them the world and we failed. So I want them to know I still have options in case things don't work out. And his mom preferred a topical to start. So I started him on topical ruxolitinib, and we have some photos of how it looked before we started and then what happened 6 to 8 weeks afterwards. And he had a really nice result. So on exam, you see significant clearance of the atopic dermatitis. And importantly, you're not seeing any white marks pop up in areas where he was treated. Because one of the concerns the parents had from a treatment goal standpoint was they, one, wanted something that was easy to adhere to. Because he'd had these combination regimens in the past where there was a topical steroid and a calcineurin inhibitor. You're going to use this twice a day for 2 weeks and then only use it on the weekends and use this other agent Monday through Friday. He's 17. He cannot keep track of this stuff. So that was a bit of a challenge for him. And they also wanted something that didn't necessarily have steroids in it because of the hypopigmentation he'd had in the past with the topical steroids. And they wanted fast itch relief because, as you recall, he had pretty significant itching to start out with. Would you have done anything different for him, Shanna?
I love the fact that you brought up, giving the patient options and also keeping things simple, especially for our young teenage patients or preteen patients. We often want to be these mad scientists that create these wonderful regimens for patients in AD and acne and a lot of the different disease states that we treat. But then once, we send this patient home with 2 or 3 tubes and only use this on weekends and only use this every other, Saturday and what have you, it ends up getting so confused. And, the patients oftentimes will bring me a bag of creams back and say, I don't know where to use what. I forget if I'm supposed to put this one on my elbow or on my eyelid. So giving patients one cream that they can use anywhere and something that really significantly can reduce their itch, that's going to help them drive compliance. That's going to help them, continue with that regimen that we want, because they will get, really early efficacy, hopefully, with that a nice reduction in their itch scores from the ruxolitinib, and they will continue to be compliant with that product. So typically, when you're looking at a patient with like that 7 to 10% BSA, what are going to be the systemic options that you would have offered Xavier?
So it's interesting. By virtue of the BSA alone, he doesn't meet criteria for moderate to severe disease, but
Right.
based on IGA, he does meet criteria. So that would be another conversation. And my rule of thumb is as long as there's no issues with the FDA label, like from an age standpoint, I offer them both the orals and the injectables. I've been very surprised over the years as to what my patient picks. And even if I have reservations about one medicine versus another, maybe I think they wouldn't go for a shot. Maybe I think they think a pill is too cumbersome. I just try to leave those biases at the door because you'd be surprised what patients would rather do. And I feel like if they feel they have a part in the process, they're going to buy into it. They're going to be more compliant. And another piece of the regimen isn't just what I'm giving them from my standpoint, but what else are they putting on their skin? Because patients who come from a variety of racial and ethnic backgrounds, they may have other organic, holistic, natural products that they use. And natural isn't always better in the case of our skin of color patients, but culturally competent care is something you have to remember. I can't walk into a room and tell them, yes, that moisturizer that mom and grandma and great grandma use is the worst thing ever, because I'm going to lose the trust right then and there.
Absolutely. And the patient's buy-in is so important. You want to make sure that we have their best interest in heart and that we understand what's going to be important to them and what they are willing to do for themselves. I love the fact that you gave him the option of topicals versus a pill versus a shot, because sometimes they may only want a shot once a month. But the fact that he wanted to apply this is going to make him more compliant with that regimen and ultimately get him better results.
Exactly. And actually, we did talk about two other topicals in this space as well. So, roflumilast and tapinarof, it came up in our conversation, but he was really looking for that fast itch relief. And from my experience, the real world as well as clinical trial data, it seemed like the right option. That being said, the difference between those two agents and ruxolitinib is we have some boxed warnings. And I know I have a way of talking to my patients about the boxed warnings, but what do you generally tell them so they don't freak out when they do some online research?
Right, right. We have to take a moment to have that conversation before they walk out of the door because it's a much longer conversation if they call back freaked out later. So I always make sure that that I'm getting everyone's attention, and whether it's mom, grandma, dad, whoever's in the room with us, we have that conversation, especially if they are underage. But if they're an adult patient, I just let them know that this is a medication that belongs to a class of medications that, when taken systemically and given to patients with cardiovascular conditions, actually had some scary side effects. And I don't go into every single one. I kind of lump them together as other side effects or scary side effects or side effects that you may not consider to be associated with a topical cream. But I just generally say that, I kind of address the box warning, I talk about it, I make sure that we have that conversation, and I make sure I give them the reassurance that, in my professional opinion, for their case, this is why I think it is still the best option. And what
Yeah,
about you? How do you have that conversation kind of naturally
Yeah, I feel like I
in that?
talked about it a lot more when the drug had first launched. And now I think people are understanding that as a topical agent, how much percutaneous absorption are we really getting? So I try to joke around with them that you're going to see some warnings. It
Right.
doesn't have to do with the cream specifically, it has to do with the oral pill. So if you don't eat it, you're probably fine. And then I do talk to them about some of the maximal use studies we've had. I'm like, we've had studies where people have put this on half of their body, even 90% of their body, and we haven't seen any of these safety signals. So in my heart of hearts, I don't think it's a concern, but I don't want you to read about it on Dr. Google and then get scared.
Exactly. And I mean, do we even have that conversation anymore with the TCIs when we prescribe them? They have a box warning as well. So I think you're right. The longer things are out and the more comfortable that providers get with these different box warnings with the JAK inhibitors, I think that just allows us to have that natural conversation with our patients. Well, let's
Absolutely.
dive into the next case. So meet Devante. Devante is an 18-year-old, another athlete. He has had a history of atopic dermatitis since infancy. In fact, all of his siblings have AD. There is certainly some kind of a genetic component there. He's a high school athlete hoping for that college basketball scholarship. And he gets so itchy and so uncomfortable when he sweats, which, of course, for athletes, especially in Southwest Florida, is a big deal because we are hot and sweaty most of the time. He has tried and failed all topicals. He came in with a grocery bag full of topicals that he failed in the past. And he's also had a history of a lot of skin infections. His skin does have multiple excoriations, especially on his extremities, where he's just absolutely digging at his skin. And unfortunately, he's had multiple instances of impetigo and other infections because of the broken down skin barrier. He had a pretty significant BSA, about 70%, and an IgA of 4. And the PPNRS, when I asked him on a scale of 0 to 10, how itchy are you? I mean, if he could have answered a 12 or a 15, he would have been there. I mean, this just could not sit still because he was itching so intensely.
And I think with skin of color, one thing we need to remember is that erythema that we're used to seeing classically doesn't always look red. It could be
Right.
dark brown, violet, gray, just like we're seeing here with Devante. So it's impressive that the severe rating is something that you were able to see, because sometimes even when I'm examining them, I'm not entirely sure. I'm using other tricks like side lighting, using the polarized light on a dermatoscope, just other tricks to help me really see that pigment.
Absolutely. Absolutely. That's a great point. So of course we had multiple, options here. He was not interested in topicals because he felt like he had been disappointed by topicals in the past, and really was ready to move forward with a systemic therapy. His mother at the time, I believe he was 17 when we started initiation of this medication, felt very comfortable with dupilumab and the side effect profile. So we did initiate dupilumab, and he got a tremendous improvement in the overall severity and the overall BSA, but still had some hot spots and still had some pretty significant areas, especially on his extremities. Some of those areas that were those past broken down skin barrier areas where he had had past infections. He had lichenified areas that were still just problematic, areas where he sweat and where maybe the friction of the clothing would rub, and it would still create some pretty significant itch. So we decided to continue, and this is a photo of his legs, his thighs, where he had some of those hot spots. And even with dupilumab, again, patients want 100% improvement, but we don't always get that. So he, at this point, needed something for topical relief, needed something for those little itchy areas. So I did discuss with him topical corticosteroids or some of the newer non-steroidal or beyond steroidal agents that are safe to use with our therapeutic biologics, including tapinarof and roflumilast. We decided on tapinarof, and because it is able to help with that skin barrier repair, he was able to get some really nice improvement and has had no cutaneous skin infections. And isn't that wonderful that we are able to offer that for patients with both biologic therapy and now some of the new topical therapies as well?
I think, Shanna, you made a really important point that we can't make our patients 100% clear 100% of the time. That's just not
Right.
feasible. So, having a topical to use as kind of touch up paint for when these
Yes.
flares come through and these breakthroughs are there can really help them feel in control of their disease. And I know we talked about tapinarof and roflumilast just because their label language doesn't say you can't use it in combination with the biologic. But interestingly, I like to call ruxolitinib the dynamic duo with dupilumab. And even though there's language that says that we shouldn't be using it in combination, real world case series actually suggests there's no safety signals from this combination. So in real world clinical practice, I would have used ruxolitinib in this case as well.
Yeah, that's a great point, a great option, and I can't wait for some of those studies to come out to reaffirm that as well.
Stay
I
tuned for something coming out in a couple weeks.
love that. All right. So these were some fantastic atopic dermatitis cases and some real world cases that we are all able to learn from. Dr. Shahriari, thank you so much for your insight, and thank you for being with us today. Stay tuned for future episodes of Grand Rounds in Atopic Dermatitis.